I think there's so much about dementia that's like, yes, there's no cure for dementia, but man, you can still go live a life. You've got a lot you can do.
Welcome to the Healthcare Grind, where we cut through the noise in the healthcare industry to bring you the latest trends, innovations, and insider insights. I'm Jess Harthcock, and I'm joined by my co-host, Lon Hecht, as we embark on a journey to connect early-stage healthcare companies, payer executives, and investors with the knowledge and perspectives that matter most. Get ready to grind in the fast-paced realm of healthcare innovation. And for more advanced content, go to healthcaregrind.com.
Hi, everyone. This is Lon Hecht. Welcome to the Healthcare Grind. It's great to have you back again. I'm joined by my co-host, Jessica Harthcock, and we have another great guest for you today, Kris Engskov, who is the co-founder and CEO of a great company called Rippl. Kris, good morning. Thank you for joining us.
Thanks for having me, Lon. Nice to see you guys.
It's a true pleasure. Absolutely love what you're doing. I'd love to kick off the episode, if we could, with maybe like a 30 to 60 second elevator pitch to orient the audience to what you're doing.
Love to. We built a collaborative care model that really takes an interdisciplinary team and provides care to a patient, a family, and a caregiver that are challenged with dementia. All with, really the simple goal of keeping them at home as long as possible, and particularly keeping them out of the ER and hospital, which is unfortunately a place that it's not well known, but a place that folks with that disease end up a lot. And that is our simple objective.
And probably the worst place for them to be is in the hospital. I can't even imagine. I mean, with a disease state like, it's got to be scary, quite scary to be there.
I'm sure we'll get into this deeply, but because there's not a great care infrastructure for people with this disease, right, where becomes the catch-all for folks who need help? It's the ER. And, in our case, it's not necessarily... you're right. I mean, when they get to the ER, it's a bad outcome all around because they have no idea what to do with these folks. They almost always get admitted, and they come out, if they get out at a reasonable period of time, weaker. The outcomes are terrible, and they spend an extraordinary amount of money while they're there, as you can imagine. So it's a bad outcome for everybody involved, and there's got to be a better way. That's what we're trying to create.
That's fantastic. It seems like a very relevant solution, especially with the aging population and the prevalence of dementia among older adults now. I mean, it's growing. Can you talk to us a little bit about the statistics in the population that you're serving and, what percentage of them do end up in the ER? And then maybe walk us through a little bit of that member journey so we can really understand how the patient experiences with the program, but then also maybe start to get into the business model as well.
Yeah, you got it. So, it is a big number, right? And I think I remember when I was first raising money for Rippl, I had an investor say to me, isn't this like kind of a niche thing? And I was like, no, it's not. Today in America, there are somewhere between 8 and 10 million people who are diagnosed with dementia. Big chunk of that is Alzheimer's, but there are lots of different dementias. That number is set to double over the next few years. And that doesn't even count the number of people that are, there's a gigantic population out there of folks who have the disease who are undiagnosed. And that's actually one of the big problems with the disease is, frankly, a lot of docs don't know how to diagnose it or don't feel comfortable diagnosing it. It's part of what we're doing to help with. The other thing, staggering statistic that I often, every time I say it out loud, I'm as shocked as anyone who hears it. But, when you're 85 years old, you got a 33% chance of having just Alzheimer's, which I find to be remarkable.
Wow.
Because as you all know, we're going to have a lot of folks living to well above 85 at this point. And that first boomer is going to turn 85 in the next 3 years. So we are vastly unprepared for what's coming. I think this is like, I say all the time, this is the highest probability, lowest visibility disease there is out there. We're going to have so many people who are working through this challenge, and it's very debilitating, as you can imagine. Because there's not care, people are out in a wasteland, and we got to move quick. It's a pretty urgent problem, and I don't think people in healthcare understand how urgent it is, even the folks who should know.
Well, it's amazing. I talk about this disease state weekly with my mother. There is nothing she's 80 years old, Mom, you'd probably kill me that I just said that on a podcast, but it's something that, her friends are starting to move into memory care units. Very concerning for her. It's incredibly scary. So can you tell us a little bit about what the program looks like? And then I'd love to get into business model and how you typically work with plans and others.
We took our care model actually for some really pioneering work that got done in a CMMI pilot at UCSF and UCLA. So they had some great evidence and models they ran at both those academic centers around dementia over the last few years. And really our care model is inspired by that. So we have a care navigator who's an unlicensed, really comes from kind of traditionally a care management background that is deeply, deeply trained in care, dementia, care navigation, education, right, care management. We've got a licensed social worker and then a advanced practice nurse practitioner who these three folks work together in a virtual pod to really wrap around a patient and maybe more importantly, a caregiver and family. That was the big learning from the UCSF model was, look, if you ignore the caregiver in dementia, you got no chance of trying to keep somebody at home and safe and healthy as long as possible. You got to bring them into the model really early. And that was a big unlock for us. The caregiver and the patient come together that first meeting that we have with them. We call it the golden hour. I mean, once we get someone into our care, a care navigator will spend somewhere between an hour and 2 hours with that patient and family in the first meeting, getting to know them. I was joking the other day. There's this great David Brooks book. If you haven't read it, you should. How to Know a Person. And I'm sure David Brooks, he was the New York Times columnist, he wrote this book, never thought about dementia when he was writing this book. But the book is all about how we don't spend enough time actually listening to each other and getting to know, our life circumstances. And with this particular disease, there is nothing more important. So we spend a lot of time listening and getting to know a patient, building trust. And the key to long-term dementia, longitudinal dementia care is that family knowing that they can trust that you know them as well as they know them. And in many instances, we may know their patient better than they do because we've navigated it so many times. And I'll just add one other thing. I hope I answered your question. The other really confusing thing about this is the reason people end up in the ER so often with cognitive issues is because no one's ever taken the time to explain to them the journey that you take with dementia or other neurocognitive diseases. And behaviors, a really common symptom that almost everybody with dementia has or experiences at some point in their journey. But no one ever says, hey, this is what's going to happen. Here's what to expect. Here's what to do if it happens.
So it sounds like, that care navigator that you place with that family, that caregiver, that member is so important. What other interventions do you have along that path? Besides really getting to know that member and building trust, are you deploying to make sure that they're staying out of the ED? Are you looking at SDOH issues? Are you looking at other types of therapeutic interventions? MedRec, maybe a part of it. Can you talk to us a bit about that before we get into the business model?
Yeah, we can provide a wide range of services with those two licenses and that care navigator, as you can imagine, right? But the care navigator is really, I'm a big basketball fan, so I'm going to use the point guard as the example, but our care navigator is the point guard of that team, right? They pass the ball, they take the ball back, they call the plays. They really are the primary contact for that family and patient. And they're available anytime that family needs help. That's why we did this value-based to start. I know we'll get to talk about other care models, but we really want to be available to that family and patient with as much care anytime they need it, right? That's critical in dementia. And a care navigator can do everything from, again, really basic stuff around navigation and education, really kind of oddly simple things. I shouldn't say they're simple, but very hard to find. And then, a licensed social worker can, provide all kinds of psychosocial help to the patient, but also that caregiver. We do a lot of psychotherapy with caregivers themselves because, as you all will know well, the reason people typically go to a higher level of care is because that caregiver just gives up. They just don't have support for themselves. And then lastly, a nurse practitioner overseen by obviously a doc can provide anything from, we do a lot of diagnosis. We can do MedRec. We can do, med management, a full range of clinical services. But I don't want it, the headline is that care navigator really is providing the most impactful pieces of the care in the care model. And that's also what's most encouraging because, there aren't a lot of people. I'll give you another shocking thing that I say that I surprise myself every time I say. There's hardly anybody in America who knows anything about dementia. And that is primarily because we've never paid for that care. And it's part of someone on our board will say to you, we're a care services company, but we're also a workforce transformation company. We got to get a lot of people into this space, teach them how to do this really, really well, and get them engaged with this population.
How do people end up in your ecosystem? So how do you engage a member and the caregiver and get them in? And how is it determined who are the right people for you to target? Well,
I know you said there are a lot of founders who are listening to this, as a first-time founder. Wow. I mean, you learn a lot as you go along, right? When we started a year and a half ago to recruit our first panel, we did what everybody does and tried lots of different channels. But ultimately, what we decided was our best referrals really come through primary care docs, which is maybe not surprising. Because they, as the clinician, know that person has a need and what that need is. And then oftentimes, we can really help extend their care. So, a primary care doc often has 20 or 40 minutes to do whatever they need to do. And that just ain't enough time to really be effective with dementia.
That's really generous, by the way, 20 to 40 minutes.
Exactly. Well, our pitch to, primary care docs, who again is where we get most of our referrals from, oftentimes neurologists too. We have a big practice with neurologists, really, which is we're collaborating with those docs to really get the same goal. Keep somebody at home, keep them out of the ER, keep them healthy as long as possible. Well, I was going to say there are other places we get referrals. We receive referrals from a lot of long-term care facilities. There are other places, but I think it works best when a clinician has identified a real need, and then we can, work with that clinician to get that person on board and then keep them engaged in their care, because we don't want to disintermediate a doc. We want to keep them very close because they typically have other chronic diseases, as you know. It's not just dementia. It's other things too.
Yeah, it's critical to keep them involved. So what does the business model look like? Could you tell us about that?
Happy to. And actually, some very good news, which I know we were talking about earlier, right? So when we started the company, there was no really business model for dementia navigation and care. The medical stuff was paid for to a certain extent, but without a holistic approach, it is very difficult to take care of somebody with this disease. So we kind of came at it when we founded the company and said, hey, we got to do this value-based, right? That's the only way that we can really pay for it in the right way. So we came into it convinced that we were going to convince payers and folks who held risk that this was worth paying for, because these are very, very expensive patients. In fact, I probably should have started with this because this is a big headline. It is the most expensive end-of-life disease, not a well-known fact. And it's more expensive than all these other sexier chronic diseases everybody talks about all the time, like cancer and diabetes. Dementia is well more expensive, certainly in a Medicare and Medicaid population.
Quick question there. I don't want to interrupt, but I do think this is important to know for a lot of folks because this is such an untapped area. What is driving those costs at that member's journey, at that dementia level? What kinds of things are they dealing with?
The primary cost is driven by what we talked about earlier, which is it's not the actual ER. If you actually look at, and these are Medicare statistics, if you cross the threshold of the ER with a cognitive issue, Medicare numbers, 75% of the time you get admitted because they don't know what to do with you. And then you'll sit there from 3 to 11 days because there's not a safe place to discharge you to. That's why we created Rippl. Because to try to answer your question very specifically, that is where the money is spent. And that's why these folks are very expensive. And they typically will repeat that. They will repeat that because there's no care like Rippl out there at any scale. They will repeat that cycle many times over as these behaviors get worse, as the disease progresses. We actually have a really innovative model with a large health system in the Northwest where we are helping them transition folks out of the hospital into our core model and then keeping them at home in that longitudinal care. Because that's as big as an opportunity as the actual just, keeping somebody at home. How do you get them home? Because it's very difficult to do.
You mentioned value-based care. You have like a value-based care construct. Can you tell us what that looks like? Are you taking full risk on these patients that are dementia patients, or what does that look like?
We are not taking full risk today. We would like to take more risk over time. I would describe our current value-based contracts as sort of early risk-ish type arrangements where we can, it's a PM, but a fair bit of our fee is at risk based on us delivering, the fundamental component, which is keeping somebody out of high utilization care. But certainly over time, given the expense of these patients, we hope to take more risk. And that's something we're prepared to do.
Really interesting. I know that there's a guide program, the guide model. Could you talk a little bit about that with the audience and kind of how that might be helping to transform your business?
Yeah, transform is a big word, and I think it is transformative.
I have a few big words in my arsenal.
I remember
even like 10, 12 letters, a couple of words, potentially.
I was sitting here about a year ago, so it would have been last summer, at this desk when CMS announced that they were introducing an alternative payment model for dementia. And I feel like we know, dementia is a small community in America, and we know most of the folks who operate there. And we knew it was being talked about and considered, but to see it actually drop was kind of amazing and transformative. And I don't think we even last year fully understood the impact that this would have on Rippl and obviously the opportunity to care for folks that have this disease. So CMMI announced this, 8-year innovation program that really was based on the same, care model evidence that we based Rippl on. So we were already in many ways delivering guide services before guide was announced, and we felt, grateful and lucky that we had kind of begun to get into it. Guide is more comprehensive. There's 9 pieces to the program that you have to deliver together to be successful. And it is comprehensive, and it is really encouraging because, when we make this work, this is exactly what we always envisioned. If you could give this kind of level of service to a family, they would be able to stay at home. They would be able to stay out of long-term care for longer. They would be able to sort of, maintain the sanity of that caregiver and that family. They just don't have resources, and they're trying to do this alone now. So yeah, we're super psyched about Guide. We applied. We can talk about the Alzheimer's Association in a minute, but in a joint application with the association in January, and we're accepted into the established program in April when they announced who was going to get in. And, yes, and we're going to start Guide July 1st with a really robust care model that we are incredibly excited about.
Congratulations.
Awesome.
That's an exclusive partnership, correct, with Alzheimer's Association?
It is. And I mean, as my 13-year-old daughter loves to say, the Alzheimer's Association was the OG of dementia care, right? They really were super humbled and honored that we get to work with them because they've been doing this for, decades. And I remember when we started Rippl, I would say to people, this is really true. I've watched this happen in lots of doctors' offices, right? You get a dementia diagnosis, and the first thing that the primary care doc does is say, okay, well, I'm sorry to give you this diagnosis. Here's what it means. And by the way, call the Alzheimer's Association because they can perhaps provide some resources. And really, they've been the only game in town for a very long time. And they've done a remarkable job in helping families. And now we get to work with them to really extend this into a much, much more comprehensive longitudinal model. And that's exciting.
Wow. I can imagine just as my grandmother had dementia and kind of watching our family go through that, especially my mom, helping her through that journey towards the end of life. It's a massive challenge. And I can imagine this is a godsend for a lot of families with what you're going to be providing. And good for CMMI to say, this is something we have to focus on. We need to get ahead of the curve. We have 8 years now to probably collect all the data we possibly can so we can be more robust with how we care for those members. So kind of a longer term question. What is your hope with the Guide program and the partnership that you have? Where do you want to see yourself in, let's say, 5 years?
Oh, those are giant questions, Jess. So I'm going to try to get at those a little bit at a time. Well, I mean, look, Guide is comprehensive, and we are right now figuring out how we go and execute that at 110%. And I love it for lots of reasons. I mean, I think that it's just going to be great. It's going to give people just the care they need in such a fundamental way. And I would say the biggest unlock there was recognizing, much like those models that I mentioned earlier, that the caregiver is the key here. Right. And that's what the Guide model does. It establishes that. So what are our big goals? Our goals are to get out and prove that it works the way we know it can work, because we've already been doing it to a certain extent, to enroll a bunch of folks and really learn as quickly as we can how to, I'm going to say this, I don't love this word, but streamline that model, right? Really get it up and running and begin to gather data. I think you mentioned that you know a lot about Guide, right? There's a big health equity component to Guide, which we're excited about, because about 35% of our current panel lives in rural areas that are really hard to access. Places like I grew up in, the middle of Arkansas, where it is, put aside, there's not a lot of care, but there is zero care for these conditions in places like that. And through our virtual model, right, we can get to a lot of folks that need help in a variety of ways. And that's going to be a huge unlock for those families. So I'm particularly excited about the health equity components of Guide. And where do we want to be in 5 years? I think that's an impossible question to answer. I hope that we built the largest national network of the highest integrity, best trained, most passionate care navigators, social workers, and NPs who know this disease inside and out and are really helping people stay at home and, really live with this disease, because it's not, we have two adjectives that I use all the time at Rippl. One is optimism. I think there's so much about dementia that's like, yes, there's no cure for dementia, but man, you can still go live a life. You've got a lot you can do with this disease and living with it. We talk about that a lot, but you need good care. You need good navigation. It's like any chronic disease. And then irreverency. I talk about, I'm not super good at being irreverent, but I think, we got to punch this disease in the face, right? We got to help people understand that we're going to grab them by the hand and we're going to help them learn how to manage it and give them the resources they need, because there's a lot we can do. And, this new Guide model is going to help immensely in getting this built out nationally.
By the way, great answer on the 5-year goal. I really love that. So, Kris, we're kind of getting towards the end of the episode, but I actually have 3 questions. Can we do a rapid fire, like 30 seconds or less on the answers to these questions if we can? First one is high level results. What kind of results are you seeing? If you could kind of give us just a couple of points on that. I'll tell you what they are: results, ROI, and then love to know where you are on investment. But we do have to wind down pretty quickly. So
so on results, so we've been now serving patients for about a year and a half. We've been working in a value-based contract, significant value-based contract, for about the last 5 months. So we're still pretty early, I think, in, I'm going to say clinical outcomes, although in many ways we are scaling a proven model, right? The UCSF model had remarkable clinical results and had really incredible total cost of care results. So in many ways, we're taking a proven model and we're building it out. I think, to be more specific, right? So we have really good engagement results, really good NPS results, right? Lots of, I would say, green shoots, early days here with these patients, which are notoriously hard to engage. We're bringing on, of every referral, we're bringing about 80% of the folks who come to our engagement threshold. NPS above 80, we're seeing a broad range and a spectrum of patients. Like I said, everything from rural to urban and everything in between. So again, we're pretty early, but we're on the right track. We're seeing very much what those early CMI models saw, and we're going to prove it out.
Anticipated ROI, what are you expecting on something like this?
I hesitate to try to answer that question right now, but here's what I would say. These are among the most expensive patients in the country, and there's a big opportunity for, I think, investors, payers, all these stakeholders to benefit by providing some much better care in this space.
And you said investors. So investment, where do you stand on investment, and are you currently raising and open to other investors at this point?
We're not currently raising. We raised a pretty good-sized seed round early on with some amazing investors. Our investors are Google Ventures, GV, Arch, General Catalyst, Mass General, Brigham Ventures, and F Prime. I mean, if you told me that we could assemble that kind of A-list syndicate, and they're all awesome partners, right? They're signed up. I remember Bob Nelson at Arch, when I first started talking to him about this, he goes, "How hard a problem is this?" And I go, "Is this?" And I say, "This is probably like one of the hardest nuts to crack in healthcare." And he goes, "Great, we're in. That's the kind of challenge we're looking for." And
that's how you get a moat, right? That's how you create a moat, cracking a tough problem. So that's great to know. Hey, Kris, how can people get in touch with you if they want to? Is LinkedIn the best way, or
reach out on LinkedIn anytime? We're open for business, and we're working with really signing up lots of new guide referral partners today as we get ready to take that on. We're moving to a number of new states in the back half of this year as guide starts, and then have a pretty robust plan for 2025 as we really start to ramp it. So, health systems, primary care groups that really have lots of patients who need this care and need a way to extend that care into home, we're talking to lots of those folks right now.
Great. So just for the audience, Kris, his name is spelled Kris, last name Engskov. We're going to wrap up now. Thank you for another amazing episode, Kris. It was great to have you on. Love what you're doing. Big fans. We're going to continue to watch. Really appreciate the time. If you have a chance, please subscribe to our podcast on your favorite podcast network. And also you can go to healthcaregrind.com and subscribe for more advanced content. Thank you again from Jess and I. We're going to sign off now. Have a great day.
As we wrap up this episode of the Healthcare Grind, we want to thank you, our incredible audience, for tuning in. If you found today's insights valuable, don't forget to hit subscribe and leave a review on your preferred podcast platform. Your feedback fuels our grind. For more exclusive content and updates, visit our website, healthcaregrind.com. Until next time, keep grinding, stay informed, and lead the charge in shaping the future of healthcare. This is Jess and Lon signing off from the Healthcare Grind.